So it is actually about the acute flaccid paralysis. And essentially, what I'm going to focus is two aspects. The first is about the clinical approach to acute flaccid paralysis in terms of getting the diagnosis and management. And of course, second part is actually very important in terms of the AFP surveillance. And this is part of the public health, which is very much emphasized by our KKM because of the polio eradication programs. And at the same time, we know that there's recent outbreak of polio in our neighboring country like Philippines and Indonesia. So I think it's actually timely for us to revisit this AFP surveillance so as we can do better and so as we have a high vigilant level. So with that, I would like to actually start it off with my first slides. So this is actually, if you look at it, this is actually the KKM Twitter. So it actually have a warning, so-called poster in the Twitter about acute flaccid paralysis. So remember to report.
Sorry, Dr. Teh, to interrupt you.
Yeah, no problem.
Dr. Teh, can you make your slide into a full full screen? And then
this is not a slide, is it? Okay, let me try again.
Okay, sorry, Dr. Teh.
No, not an issue, not an issue at all. So I stopped sharing, then I'll share again. How about now?
Yes, great.
This is the presentation mode, right?
Yes, presentation mode.
Okay, sorry about that. But you all still see my first slide just now, right?
Yes. Okay.
Yeah, just carry on with my presentations. If you look at the Twitter of KKM nowadays, there's actually a warning poster about AFP. And you're supposed to actually report the case of AFP to the nearest health clinic as soon as possible if there's any suspicion of the case AFP or even polio. So with that, I probably would like to actually start off with a case illustrations so as we have a better feel how a child with AFP will present. So this girl, DLL, is a 10-year-old Chinese girl who was previously well. And on the day of admissions, she attended school as usual in the morning. But after a gymnastic class, the girl started to have vomiting and suddenly became limp in the classroom and fell on the table. And subsequently, she was unable to stand and walk. Not much other history, no loss of consciousness, no seizures. And as prior to the event, there's no asthenic weakness, no back pain, no limb paresthesia, no bowel or urinary problem. And at the same time, there was no other symptoms suggestive of infections, no trauma, except the gymnastic class in the morning. There was no recent history of surgery, and there was also no significant family history. So when she presented to the casualty, you can see that she's still having a full GCS, hemodynamically quite stable. However, what you notice is that the cranial nerve were normal, both lower limb and upper limbs were hypotonic. At the same time, the power was quite weak. The lower limb almost like power of grade 0, and there were absence of reflexes. Whereas for the upper limb, there was variable power grade, particularly proximally, they still have 1 to 3, but distally was almost 0. Again, the reflexes were absent. And actually the casualty officer further to examine the patients, it shows that there was actually sensory level with the absence of light touch and pain up to upper thoracic level. So the question now is, did this case fulfill the case definition of acute flaccid paralysis? And what could be, or where could be the neuroanatomical localizations? For the next few slides, this is what I'm going to focus. It's okay for you not to know how to answer the questions. I'm not going to ask the audience now, but at the end of it, I hope that we can join a bit better about the case discussion for these DLL patients. So what is the case definitions of AFP? And these case definitions is adopted from the polio eradication programs. And it is actually defined as any case of acute flaccid paralysis in a child less than 15 years old. Of course, AFP can happen in any age, but for the polio eradication program purpose, they will only actually focus on children less than 15 years old because poliomyelitis always happen or often happen in the young children. Whereas if you look at acute flaccid paralysis, they all carry their own meaning. Acute means rapid progressions of paralysis. It could be minutes like this child, it could be hours up to days. And of course, it's not those like chronic presentation. And whereas for flaccid, it means you have loss of muscle tone, which means that there's presence of floppiness. Versus like those children who have spasticity and rigidity, this is usually not classified in the acute flaccid paralysis itself. And finally, paralysis, as the name suggests, it is a weakness or loss of voluntary movement of arms or legs. Because a lot of time, many children may not tell you, I am weak. You may actually see that they have loss of certain voluntary muscles or voluntary movement of muscles, as well as a voluntary loss of so-called muscle functions. So how do we actually approach when you have a child AFP with acute flaccid paralysis, like in this case of the DLL? The first questions, this is how I approach it. The first question I probably will ask is, it is a true weakness. The second question I want to ask is, what is the extent and severity of weakness? The third is, what or where could be the neuroanatomical localizations? How to ascertain localizations? What can be the underlying cause? What are the relevant investigations that we are going to carry out? And finally, what should be the management in terms of acute settings, supportive as well as definitive? I'm sure whoever referred a case to me in Penang, I always will ask these 7 questions because, so in case you are going to recur any case in future, please be ready with these 7 questions, the answer for these 7 questions, because this will be very helpful in terms of the further investigation as well as management of the child with AFP. Now I'm going to move on to actually focus on each of these segments so as we will get a bit more idea how to approach better. The first question is there a true weakness? Why do we need to ask this? Because a lot of time there are other mimicals for acute flaccid paralysis. So in the first place, we need to rule out what? The first thing is, the child can't walk. Is it because it's septic and lethargic? Because a lot of time the child may not be able to walk or may not be able to carry out the normal motor functions. It's because just generalized weakness or generalized letharginess. So that is very important first question you ask yourself. It is just because of lack of energy. A second thing is it could be sometimes related to cardiac or respiratory origin. Luckily, those children may have reduced effort tolerance, like such as you may have cardiac failure or some respiratory distress. Of course, the next question is always very important. We do actually have quite a few cases referred as acute flaccid paralysis. In fact, they have septic arthritis or transient synovitis, or even just a bone pain. So remember, orthopedic causes such as any injury or any disease involve the soft tissue, joints, or even bone. They can present mimicking acute flaccid paralysis. And the next is not uncommon. And we got a lot of referrals about the child with inability to walk. In fact, it is because of ataxia. And that is the reason it's always very important for us to look at, or for us to decide whether the inability to walk is because of incoordination or clumsiness due to cerebellar dysfunctions. So these are probably the 4 important questions for you to think about when you see a child with so-called inability to walk or loss of the normal motor functions, because these are the mimicals. Once you are convinced yourself, yes, there is presence of weakness, then the next question is very quickly you need to decide the extent and severity of weakness, because this is very important for us to initiate the acute management, not waiting for us to just get a diagnosis. So how do we look at the extent and severity of weakness? First thing, you look at what are the limbs involvement. Ranging from mono, hemi, para to quadriplegia. So if somebody presents to you with quadriplegia, that is actually a medical emergency because they potentially may involve our respiratory so-called function as well. So that is important. When you see a child with true weakness, yes, there is acute flaccid paralysis. How much the action of the weakness? And at the same time, it is actually very equally important for us to look at whether distal or proximal weakness, but this is actually more important in terms of localizations, which I'm going to talk about later on. And sometimes you may ask me one question. Example, that you have a child of 6 months or even 9 months old child, they will never complain to you whether they have weakness or not, right? I'm sure a lot of you have experience with 1-year-old child inability to walk or refusal to walk. So how do we actually know the extent and severity of weakness? That comes to in very important for us to know the motor milestone. So a lot of children, they always have some pre-morbid motor developments. So for the pre-morbid motor development, you need to get some idea what were the previous gross motor status of this child, whether he can sit, cross, stand, walk, or climb staircase. Or fine motor skill, how about the pencil skill, whether he can open books, turn knob, lift up object, or combs the hairs. So these are some of the motor skills that perhaps you need to elicit prior to the so-called identification of the functional change. So in other words, that if the parents tell you that previously he can crawl, then now he actually lost the crawling skills. Perhaps this could be a case of acute passive paralysis. It may not complain directly to you that I have weakness for a 6-month-old child or for a 9-month-old baby. So that's the reason sometimes to know the weakness, we probably need to know what is the regressions of the motor milestone. And from that, perhaps we will know, yeah, this case is probably a child with acute passive paralysis with a high index of suspicion. So in other words, that for younger children, it is always important to look at the motor regressions, could be in the acute setting, which could be a sign of acute passive paralysis as well. So next, for us to understand and for us to identify the neuroanatomical localizations, it is always very important for us to have some ideas about the motor pathway. I mean, exactly like as comparison to when you want to find out a cause of a respiratory problem, a lungs problem, you need to know the anatomy of the lungs. And similarly, in a child with acute passive paralysis, we know the major parts of the involvement is actually the motor pathway. Of course, there could be some other neurological system involvement as well. But when you say passive paralysis, of course, what will be the involvement? It will be the predominantly motor pathway. So this is actually a very basic cartoon to actually shows the motor pathway. As you know, the motor pathway start off with the motor cortex, and representation is actually over the precentral gyrus in the motor cortex. And further, you will see the nerve fibers for the upper motor neurons will traverse through the white matter and going through this internal capsule. And further, they will going through the midbrain, particularly at the ventral aspect of the midbrain. Or subsequently, they will reach the medulla. And this is the most important, this is one of the important part of the motor pathway, because our motor pathway crossed in the medulla. In other words, that if you have any lesions prior or proximal to the medulla, you are going to have a contralateral weakness. But if you have any lesions below the medulla, then whatever lesions in the motor pathway will cause ipsilateral weakness because it has crossed over to the opposite side. So that's actually very important. So once you reach the level of so-called the spinal cord, and they will actually decussate with the so-called lower motor neuron, which is the anterior horn cells, or we call it lower motor neurons. And subsequently, you will have the peripheral nerve fibers and reaching the neuromuscular junctions, and finally, the muscles. So in other words, that this is actually the motor pathway, and any part of the motor pathway get involved or any disease, then you may have a possible presentation of acute passive paralysis or any motor weakness. So this is actually a summary of whatever I mentioned just now. When you see a child with possible acute passive paralysis, what could be the localizations? It could be at the brain itself, either motor cortex, white matter, internal capsule, or sometimes even the extrapyramidal system like thalamus and basal ganglia. The next is it could be at the brainstem, the spinal cord, at the cortical spinal tract. And when it come out, it could be the nerve root, it could be the plexus, peripheral nerve, neuromuscular junctions, as well as muscles. I think in this cartoon, I missed one area, is actually the anterior horn cell itself. This is particularly the area of involvement for poliomyelitis. So for acute passive paralysis, often these are the area of involvement from the spinal cord up to the muscles. Of course, we do have some mimicals when they have a brain involvement and brainstem involvement as well, but the neurological side will be a bit different. So next, move on to how to ascertain the localization. So I always actually will look at two aspects, the motor as well as other neurological examinations such as sensory, sphincter, as well as other functions of neurology. So when we look at the motor examinations, these are the important things that you should look at to ascertain the localization. First of all, you try to look at the anatomic distribution of weakness. In other words, that exactly like what I mentioned just now, what is the pattern of limb involvement? Either paraplegia, quadriplegia, monoplegia, or even a hemiplegia. Then you would like to know whether it's distal or proximal weakness. We're going to talk about the importance of whether it's actually a distal or proximal involvement in terms of the neuroanatomical localization later on. And besides that, not to miss about other muscle involvement, which include the facial involvement, extraocular muscle, bulbar functions, and respiratory functions. Because this area also equally important in terms of the muscle power, not just the limb power alone, particularly true for bulbar as well as respiratory muscles. And next, you're going to look at the chronology of weakness, because you know, as an acute facial paralysis, you need to know how quick the onset, the sequence of events, which means that whether they start off with the face on bulbar function or whether they start off from the lower limbs up to upper limbs, and the cause, how actually dramatic, like this child, remember the DLL, it was very dramatic within a few minutes that the child have acute facial paralysis. And of course, when you examine the mode of examinations, that will include your deep tendon reflexes as well. And next, it is equally important not just focus on the motor functions, but also the sensory involvement, either in a dermatomal deficits or a sensory level. But again, in young children, this is not always possible because it will be very challenging for a child to complain to you whether they have a lost pain sensation or even a loss of proprioceptions. But for any children who actually can complain and actually can describe to you, remember to examine the sensations, because this is equally important for us to localize the lesion. So of course, next, this is always missed, and because whenever people refer to me for AFP, I will always ask this question. Please remember to check the bladder and see whether the bladder is palpable, any urinary retention. And of course, remember the bowel, whether there's any lacks of inner tones, because that will be the sign of either spinal cord involvement or autonomic dysfunctions. So again, sphincteric control is very important examinations in the neurolocalizations for any child with acute facial paralysis. Otherwise, it's always important, equally important for us to know the adult neurology, including the consciousness, the cortical functions, any presence of extrapyramidal abnormalities, such as like you have any dyskinesia or dystonia, any cranial involvement, any autonomic dysfunctions, as well as cerebellar system. So these are probably the components is important for us to localize the lesions. And now we're going to move on from here to each of the level and what will be the characteristic of the clinical sign. But before that, I just try to have a quick revisions about how do we localize whether it's central or peripheral cause. I guess most of you will know. When we say upper motor neuron lesion means it is due to central cause. When you say peripheral, so-called hypertonia or peripheral involvement or peripheral lesion, this is related to lower motor neurons lesions. And for upper motor lesions, it is because of brainstem or brain or even spinal cord involvement. And generally, they are hypertonia, pre-reflexes, as well as upgoing plantar. But bearing in mind, quite a number of cases with the acute setting of central involvement may have hypertonia. Example like an acute stroke, acute spinal cord infarct, acute spinal cord tremors, myelitis. Before they evolve to hypertonia, they may be having hypertonia as the initial presentations. That is the reason sometimes certain cases of acute facial paralysis could be due to a central cause or upper motor neuron lesions. And secondly, it is quite simple because most of these causes will present acute facial paralysis, and the level include anterior horn cells, which is the lower motor neuron, peripheral nerve, and neuromuscular junctions, or the muscle itself. And we are quite familiar. Generally, they should be hypotonia. They will have depressed, or some of the cases may have normal reflexes, and they always have downgoing plantars. I mean, in certain cases, sometimes you may have equivocal plantars for both central as well as peripheral hypotonia or peripheral weakness. So move on with each of the level. I'm just going to focus on the level, particularly we'll present with acute facet paresis. I'll start out with the spinal cord first. I'm going to actually highlight to you what are the characteristic signs that we can elicit so as we know, yes, this is the level of involvement. Okay, first of all, if you have an acute myelopathy, which means that you have an acute spinal cord problem or disease, most of the time, they either present with quadriplegia if it involves the cervical cord. If it involves below the cervical cord, they usually present with paraplegia. And of course, the reflexes tend to be breached and outgoing plantar. But we have seen a couple of cases, they do have an equivocal plantar as well. So this is not always true, but be careful about the plantars. Most of them, actually, the spinal cord will have outgoing plantar responses. So this is motor involvement in the spinal cord. But what is more important is if the child can complain to you, the child can be cooperative, then the sensory examination will be a telltale sign. Because usually those have acute myelopathy or spinal cord injury or spinal cord disease, they will have a sensory level. So please check the sensory level. In this cartoon, it shows you the so-called dermatomal involvement. And each dermatome actually shows you the level of involvement in the spinal cord. And bearing in mind, a vertebral level doesn't correlate with the spinal cord level. In other words, let's say you have a vertebral injury at the level of T1. It doesn't mean the spinal cord level is T1 because they're actually quite different in terms of the level for the spinal cord involvement. And this basically shows you is more of the spinal cord level, not the vertebral level. Okay, just remember. And the other very interesting sensory involvement in the spinal cord is dissociated sensory modality involvement. You know that actually in our spinal cord, this is a cross section of the spinal cord, there are two important tracks for our sensation. The first is actually the dorsal column. You can see my cursor here. The dorsal columns control the fine touch, proprioception, as well as vibrations. Whereas the spinal thalamic tract control the pain and temperature. This is totally two important different tracks. I'm going to tell you what is the importance about differentiating these two tracks later on. So as mentioned, if you have a complete transection of the cords, what you have is a sensory level with a paraplegia. And the sensory level, for example, like a T10 involvement. However, sometimes things may get a bit more complicated when you have a left-right transection of the cords. Example, like you have a right transections of the thoracic cord. What you have is ipsilateral weakness. As I mentioned, the cortical spinal tract for the motor have already crossed over at the medulla. Any lesion below the so-called the medulla will have ipsilateral weakness, and you will have a contralateral so-called sensory involvement. Because for the spinal thalamic tract as well as dorsal column, the nerve fiber actually cross over at the level of the spinal cord. So in other words, when you have right transections of the cord, what you have is sensory loss over the contralateral side. But you may have some sensation involvement at the ipsilateral side because you have a so-called nerve fiber I haven't crossed over. So in other words, that when you have a ipsilateral muscle weakness with a contralateral sensory involvement, it actually tells us that there is actually a semi-transection of the cord or half of the cord are diseased, half of the cord is diseased, and this potentially will tell you that yes, those area of involvement is ipsilateral to the motor weakness. So this is sometimes called a brown scratch syndrome. But things are more interesting is that when you have these anterior spinal artery syndromes, example like you have these lesions at T4, the reasons why you can present an anterior spinal lesion is that our anterior spinal artery is supplying the anterior two-thirds of our spinal cord. So when you have a thrombosis or embolizations to the anterior spinal artery, whatever involvement is actually the anterior two-thirds of the spinal cord for both sides. So in other words, that you will have actually a spinal thalamic tract involvement by which there's presence of sensory level for both pain and temperature because of the spinal thalamic tract involvement. But you will have a dorsal column example like proprioception and vibration spared because the dorsal column is supplied by the posterior spinal artery. So whenever you have a child with a sensory level, it is always very important for you to check the proprioception and vibrations because we want to differentiate whether this is a full cord involvement or whether this is the anterior spinal artery syndrome. Because once you have a child with a pain and temperature involvement with the sparing of the proprioception and vibration, it will actually convey an important message that the posterior column is intact. In other words, that you really need to look very hard whether this could be anterior spinal artery thrombosis or even embolization. So sensation is very important for us when you assess acute myelopathy. So the other very important clinical sign is loss of sphincteric control. We know that when you have an injury to the spinal cord above or even at any levels, you will have a so-called pelvic splenic nerve over here. And you know that pelvic splenic nerve control both our bladder and bowel. So in other words, that when you have an acute spinal cord disease, most of the time you will have a loss of sphincteric control. In other words, that they may have a urinary retentions, they may have a bladder palpable with the legs or anal tone. So these are the three important characteristics with the motor involvement. It could be paraplegia, quadriplegia. With the sensory involvement, it could be present with the sensory level involvement or dissociated sensory modality involvement, and finally with the loss of sphincteric control. So when you have these three characteristics, it will really point towards the level of spinal cord. Moving on from spinal cord, we are going to look at this anterior horn cell and lower motor neurons. This is actually a lower motor neurons. Okay, this is supposed to be decussations between the upper motor neuron as well as lower motor neuron, and it is actually at the ventral horn. That is the reason we call it as anterior horn cell, because it's actually located at the anterior horn or the ventral horn of the spinal cord. And typically, they have witnessed, it could be any pattern. However, it tends to be monoplegia. I mean, we have quite a number of experience during the EV71 outbreak. Those children present with acute facet myelitis tends to involve the anterior horn cells. And most of the time, you will see them present monoplegia, but it could be any of the limbs, either upper limb or lower limbs. And this EV71 nowadays is actually coined as the so-called a new polio, because they present almost like polio, but of course they are not polio viruses. And at the same time, one other typical findings in this anterior horn cell disease is those with absent reflexes, presence of fasciculations, if you can see one, but this is, I must say, this is very rare. I personally haven't seen fasciculations in a child with those like monoplegia due to EV71 infections. But typically, you know, this is just anterior horn cell, which is only a motor neuron, so they don't have any sensory involvement. So that's another important characteristic in terms of anterior horn cell disease. So moving on from the anterior horn cell, once the anterior horn cell up from here, so you will have this so-called a nerve fiber. So any disease of the nerve fiber we call as radiculopathy. So in other words, that when you have a radiculopathy, usually they'll follow two important clinical characteristics. For the motor involvement, you can look at here, you will have a myotomal involvement because it depends on the level of the spinal cords. Examples like you may have a C2 until C8 involvement, you may affect your sternocleidomastoid, you may affect even the diaphragm, trapezius, bicep, brachioradialis, tricep, and wrist extensor, and even up to the wrist flexor if it's up to the C8. So this is actually so-called a myotomal muscle involvement. At the same time also, for the sensory involvement, there tends to be dermatoma. Dermatoma, again, this is like a level, sensory level. But of course, they may not have a sensory level like whatever sensation lost below. It will only have a corresponding sensory involvement in the dermatoma pattern. But let's say, for example, you may have a T2 involvement, you may just loss of this area of sensations. But versus when I say sensory level of the spinal cord, you say sensory level of T2 means everything lost below here. So of course, the other thing is important when you want to find out whether this is actually a nerve root or a so-called a certain spinal cord level involvement, you can actually check the reflexes. Absent or certain reflexes will indicate a certain level of involvement. And typically, those have radiculopathy, they tend to have some radicular pain in terms of sensation involvement. So next, moving on, after we have the nerve fiber coming out is actually the plexus. You do have a lot of important plexus like upper limb brachial plexus, lower limb like lumbosacral plexus or sciatic plexus. And all these plexus sometimes may get involved in disease as well. But they're not so common in terms of a presentation of acute facet paralysis, except that you may have some patient with brachial neuritis or brachial injury, brachial nerve injury. They sometimes can present a plexopathy, which is a kind of acute facet paralysis as well. And these plexopathy, again, they tend to be myotomal or dermatomal, but at times they could be a combination of multiple peripheral nerves of the same plexus. I mean, you are quite familiar with the upper trunk involvement in the brachial plexus. You will present with typical Klumpke, the typical Erb's palsy, and for the lower trunk, you will present with so-called Klumpke palsies. So this is actually the example of plexopathy, which can present sometimes as acute facet paralysis. And next, after the plexus, we have this nerve root radiculopathy, you have flexus and plexopathy, then you have peripheral neuropathy. So again, peripheral neuropathy for the motor, typically they have absence of reflexes and tends to get involved distally more than proximal, because any demyelinating disease usually they tend to involve the land-dependent area, which is the distal area. And for the sensation involvement, it tends to be glove and stocking patterns. So like these pictures. So in other words, that when you have any peripheral neuropathy, you may tend to see distal involvement prior to the proximal involvement, and the sensation involvement tends to be a glove and stocking pattern. Of course, the commonest presentations for this peripheral neuropathy is because of the Guillain-Barré disease. We always get trapped sometimes. We thought it's almost always true that you need to have a distal involvement more than proximal to label at somebody having acute inflammatory demyelinating polyneuropathy like GBS. But sometimes things get a bit complicated. We do have mixture and combinations. As you know, this demyelinating disease not always follow textbook. So when you have a child with proximal and distal equally involvement, or some of them have slightly more proximal involvement, don't dismiss the possibility of GBS if there is absence of reflexes. This is always very important. When you have absent reflexes, it's very important clues. But distal more than proximal is just some clues, but it's not always true. So the other very important involvement, sometimes we do see some GBS, but up to 10% of them have actually like bladder and bowel involvement. But again, bladder and bowel involvement, the first thing should click your mind about myelopathy, spinal cord involvement. But uncommonly in peripheral neuropathy, you do have all these so-called sympathetic and parasympathetic nerve fiber, and they could be involved in the demyelinating process as well. So uncommonly, you may see in the peripheral neuropathy, you have autonomic involvement like cardiac. Cardiac, some of them may have hypotension, arrhythmia, because in the GBS, because of the dysautonomia, because of this peripheral sympathetic and parasympathetic nerve involvement. And of course, some of them may have gut involvement and also the bladder and bowel involvement as well. So moving on to neuromuscular junction disorder. In the neuromuscular junction disorder, example like a myasthenia gravis, you tend to have either normal or diminished reflexes. And what is more pathognomonic is the extraocular muscle involvement. A lot of these children with myasthenic or neuromuscular junctions problem, they tend to have extraocular muscle involvement. And interestingly, it always shows the phenomena of fatigability. What do you mean by fatigability? In other words, that usually the more you use the muscle, the more the muscle will get fatigued. And of course, usually they will improve after rest. So some of parents may tell that, yeah, in the morning actually you feel better, and at the end of the day, actually the child get weaker. So this is actually the evidence of fatigability that will raise the suspicion of possible neuromuscular junction involvement. And this is neuromuscular junction, nothing to do with sensation, so they badly sensory. Finally, is the muscles. So muscles, quite simple. Again, usually for any muscle involvement, you tend to be proximal weaker than distal. The reason being because our proximal muscle usually have a bigger bulk. So that is the reason it will be any disease involve the muscles, the biggest amount of muscle will get involved more than distal. So that is the reason you typically have a proximal weakness in myopathy. And the reflexes can be diminished or normal. And lots of times, I mean, they will present with some muscle pain or cramping. And sometimes you have myoglobinuria due to some muscle breakdowns, example like myositis. Again, this is muscle disease, so it's bad the sensations. So you don't have any sensory involvement. So basically, I have covered the so-called characteristic signs for neuroanatomical localizations, spreading from the myelopathy, the spinal cord involvement, to the anterior horn cell disease, to so-called radiculopathy, plexopathy, peripheral neuropathy, neuromuscular junction disorder, until finally myopathy. So I hope you all get the important sign of localization. So when you examine, so as you can get some idea what could be the level of involvement. But in sometimes, this is just an ideal situations. We may have some conflicting sign here and there because against for children or for so-called patients, they don't always follow textbooks. Sometimes you may have a mixture of signs, so don't get confused. You need to see what are the core signs in terms of the examinations. So after we have actually localized lesions, as a neurologist, we will always like to localize lesions, then we will move on to what could be the underlying etiology. Just moving through the so-called important causes, if you look at the spinal cord, it could be vascular, compressive, or inflammatory lesions. Compressive, example, you may have trauma, some abscesses, like epidural abscesses. It could be due to TB or even some pyogenic abscess, or it could be hematoma because of injury. And vascular, as I mentioned, it could be due to anterior spinal artery infarct or occlusions. Inflammations, typically like a transverse myelitis, examples like due to some autoimmune disease like the neuromyelitis optica, and some of these, even the example of like multiple sclerosis, all this can present transverse myelitis with a cord involvement. Whereas for anterior horn cell, typically it's actually viral in etiology. Example, your poliomyelitis, or it could be enteroviral myelitis, as I mentioned to you. This part of the world, usually we see quite a number of patients with EV71. For the root and nerve fibers, that means, in other words, that this could be a plexopathy, radiculopathy, or neuropathy. It could be actually some form of immune-mediated para-infectious, like Guillain-Barré syndrome. And you could have some viral involvement like rabies. You could have trauma, and you can have toxin, particularly like post-diphtheria. Again, we are seeing the re-emergence of diphtheria. Sometimes just be cautious. Post-diphtheria, they can present with peripheral neuropathy like GBS mimicals. And you may have other very rare conditions like porphyria, arsenic poisoning, or even lead poisoning. Sometimes they can present with the peripheral neuropathy as well. Whereas on neuromuscular junction, typically is myasthenia gravis. But bearing in mind, you could have other toxin and drugs can affect the neuromuscular junction, example like organophosphate, some venoms, and as well as botulinum toxin. So these are the causes also for the neuromuscular junction disorder. And finally, about the muscle disease, it can range from infections, inflammation, channelopathy to electrolyte imbalance. So infections like myositis, recently we've seen quite a couple of patients with influenza-associated myositis. So they can present acute facet myelitis, acute facet so-called paralysis. Of course, inflammations, the inflammatory myopathy, like certain autoimmune disease. And you can have channelopathy, like typically this hypokalemic periodic paralysis. And of course, some of children with the diarrhea, vomiting, you may have an electrolyte imbalance like hypokalemia, hypocalcemia, could actually present with muscle weakness, mimicking the acute facet paralysis. So essentially, after you have done the neuroanatomical localizations, what you need to move on is to identify the underlying cause. So, but sometimes identify the underlying cause, I thought it's actually quite helpful to ask some other further history, because sometimes in the examination itself may not help you in terms of the etiology. So your history taking sometimes will be very relevant. So examples like when you have a fever, weight loss, rashes, joint pain, systemic symptom, you are thinking about some form of autoimmune disease. You have a recent illness immunization, of course, you are thinking of whether this could be para-infections or immune-mediated, or actually related to some immunizations. This could be some form of presentation of a Guillain-Barré syndrome. And if it's related to some recent travel history, you may have tick spike, then it could be the cause of Lyme disease with actually neuropathy as well. Some other precipitating factors may actually be the telltale sign, example like you have a carbohydrate. I mean, if you have exertions, then you become weaker. This typically happens in periodic paralysis. And when you have a fluctuation in the weakness, the diurnal variation, fatigability, this is typical in myasthenia gravis. Or definitely a drug and toxic history exposure is always very important. Like when you have a bad food, so-called canned food, you will worry about botulinum toxin, pesticide, organophosphate. Statin sometimes can cause, this is usually more for adults, they're using for cholesterol-lowering drugs. And sometimes it can cause myopathy, but not so much, not so common in children because as less it's accidental injections of the medications. Of course, lack exposures. And family history, if you have family history of weakness, like in a couple of patients in the same family, be careful about these conditions of porphyria. And there are also some specific patterns recognized so as we know what could be the underlying etiology. Example, you have bulbar predominantly involvement. Yeah, it could be actually the botulinum or myasthenia gravis, particularly those anti-MuSK involvement, I mean the anti-SK antibody, or some of the pontine lesions. And when you have a ophthalmoplegia or motor weakness, it could be GBS with the Miller-Fisher variant, or it could be some botulinum, or it could be some cause of like myasthenia gravis. Whereas you have a prominent autonomic dysfunction, it could be Guillain-Barré syndrome, botulinum. The other thing, of course, is actually the spinal cord involvement. So this specific pattern recognition sometimes will tell us the underlying disease as well. So after we note the possible etiology, because we get from the localizations, the next thing to move on is our investigations. And it is always important, it's actually based on the suspicious and underlying cause to elicit or to actually further plan our investigation. And these are the list of investigations that you may consider based on your clinical suspicions. Example, like after the examinations, you thought this could be a spinal cord level or myelopathy. Of course, MRI spine is very important. And bear in mind, I will always suggest you to do a contrasted MRI spine. The reason being because some of the myelitis may be enhanced by the contrast. I mean, our experience during the EV71 outbreak, we have a couple of patients with acute facet myelitis with the anterior horn cell involvement. There are about 20-30% of them actually been enhanced with the contrast during the MRI spine. And sometimes if it's non-contrasted spine, MRI may not see the lesion very well. So that's the reason we always suggest to do the contrasted MRI. The other thing is I put a bracket here for the GPS. Because, of course, MRI spine is not a modality of choice to diagnose GPS, but sometimes it may be helpful. Particularly, if you ask them to do a lumbar sector spines and look at the nerve fibers, some of the nerve fiber may be enhanced by contrast in the MRI spine. And that will give a clues of the evidence of GPS as well when you have a so-called nerve root enhancement in the MRI spine. So this is actually very important for us to elicit further in the MRI spine when you look at the contrasted MRI. And sometimes you can ask your radiologist and see whether the contrasted MRI shows any clues about the peripheral or so-called the nerve root enhancement. And secondly, it's about CSF. Yeah, this is actually quite useful test, but unfortunately, this part of the world is not easy to get a consent from parents. But it's always important if you think there's suspicions of a spinal cord involvement. Yeah, example, like you have myelitis, you definitely want to look at the cells and protein, or even you have a GBS, you're not very sure. Yeah, but if you have evidence of a raised protein with a normal white count or with a normal cell count, we call albuminocytological dissociation. And this is actually very suggestive of GBS. So in other words, that when you think about inflammatory disease in the cord as well as the peripheral nerve or nerve fibers or nerve root, yeah, CSF will be very useful for us. And next is actually a lot of times they refer to us for NCS and EMG. Yeah, I must say actually the gold standard of diagnosis for GBS is actually the NCS and EMG. But at times, it doesn't mean that you need to wait until the NCS and EMG before you can initiate the treatments of GBS. Being that if you know that clinical presentation is very typical, if you have the advantages of a CSF with a high protein and normal cell count, if let's say you have done an MRI with a peripheral nerve root enhancement, sometimes that's actually good enough for us to initiate the treatments rather than wait until get transferred to our hospital to do the NCS. So in other words, that you may actually suspicious or high suspicions of GBS even sometimes without the NCS. But in equivocal cases, yes, I think a lot of time we will need to do the NCS and EMG just to make sure we don't actually miss other mimicals. Of course, besides GBS, NCS and EMG sometimes will be helpful for those anterior console disease. And if you think about this myasthenia gravis, sometimes repetitive nerve stimulation may be adding the advantages of a diagnosis of possibility of this neuromuscular junction disorder. Of course, a lot of time we will do the blood test. And these are the important blood tests. You know the CK, you know CK will be raised in myositis or any muscle disease. Potassium, calcium, magnesium, phosphate, these are all electrolytes that will potentially cause apparent myopathy if you have an imbalance of these few electrolytes. And if you have an evidence of myelitis, then of course you will do some antibody that will usually associated with myelitis, is aquaporin 4 and MOG. So aquaporin 4 usually associated with neuromyelitis optica, and a lot of times they may have some brain as well as eye involvement. Of course, MOG sometimes may have spinal cord involvement, but they are usually tends to present like ADEM, the acute disseminated encephalomyelitis like of a presentation. And if you think about autoimmune disease, then you have suspicions of you need to do this ESR autoimmune screening. And the other very important thing is you may need to consider doing an ECG if, let's say, you are still waiting for a potassium level to come back, see whether any hypokalemic changes. And very rarely you need to do this porphobilirubin in the porphyria or even toxic assessment like lead and arsenate. So in other words, that you do have quite a number of investigations to be done, but of course you can do some basic tests and tailor other tests according to the clinical suspicions. And finally, I don't want to miss that. Remember to always send your stool for polio viruses and other enteroviruses. I'm going to talk a bit more about this AFP surveillance and poliovirus and poliomyelitis later on in the second part of my presentations. Okay. So back to this case. This is DLL. Again, just to remind you, this 10-year-old Chinese girl previously well with acute weakness after the genetic class. These are the examination findings. I think we know just now. GCS full, normal cranial nerve, but she have quadriplegia, a lower limb involved more than upper limb. There's presence of sensory level and absence of light touch and pain up to thoracic level. So, what should we do next? So what other physical examinations that you will try to elicit? I'm not sure, should I ask the audience or will they answer it? What do you think, the organizer? Or should I just proceed? No answer for the audience? Okay, I think this is the first talk. Everyone is still sleepy. Never mind, I will move on. What other physical examination you want to know? Of course, plantar responses, equivocal. You just can't get anything. Then the bladder is palpable. Anal tone laxed with the absence of saddle sensation. Saddle sensation is actually a perinatal sensation, perianal sensation. And the proprioception and vibration were intact. So what is the neuroanatomical localizations? I think we went through just now, right? Any idea? Okay, no answer. I'll move on. So what could be the localizations? Yeah, definitely it shows evidence of myelopathy, right? You know, quadriplegia. Yes, quadriplegia, we're very worried about whether the cervical cord involvement. Then you know you have a sensory level. When you have a sensory level, of course, you also have very worried in terms of the spinal cord involvement. But interestingly, you know that there is dissociated sensory modality involvement. So could it be this anterior spinal cord syndrome? Yeah, as I mentioned just now, the spinothalamic tract involved with the involvement of pain and temperature, and then sparing of the dorsal column, which is a proprioception. So, the most likely diagnosis could be acute spinal cord infarct due to anterior spinal artery thrombosis or embolizations. Of course, there are some patients of spinal cord hemorrhage involved the anterior cord also can present that way, or even some thrombus myelitis and involved just selectively over the anterior cord, you may present similarly as well. So, of course, what is the investigation of choice? You worry about myelopathy. So, you worry about myelopathy, but you know there's actually likelihood to be cervical cord involvement. So, the cervical MRI will be the most important investigations. And as you can see here, this is actually a T2 sagittal view of our cervical cord. There's actually a marked swelling over the cervical cord ranging from C2 up to almost like T1. It is actually very extensive movement of the upper cervical cord. And I'm not sure it come up well, but if you look very carefully, there is abnormal hyperintensity just over the anterior cord itself, probably about half or two-thirds of the anterior spinal cord. And again, if you look at a bit more details, in the T1 images, there's a hyperintensity in the cord. This now I show the first one was T2. When you have a T1 hyperintensity, it means some hemorrhagic components. So in other words, that what you have here is actually a long segment spinal cord involvement with edema. It was quite extensive from T2 to T1 and predominantly affecting the anterior cord and both gray and white matter of the cord. And T1, there's present hyperintensity, could be some hemorrhagic transformations. So this case is actually very highly suggestive of spinal cord infarct, likely due to the anterior cord spinal artery involvement with some hemorrhagic transformations. Again, I think this child is not doing very well, even though despite initial we thought it could be a thrombus myelitis. It was given methylprednisolone plasmapheresis, but nothing seems to be helping her. And of course, at the end of the day, we look at the MRI itself, it's actually more suggestive of spinal cord infarct rather than myelitis. And the outcome is actually quite poor for any children with spinal cord infarct. So how do we manage? Let's say this child DLL came to you. Remember, I put the words that any case of acute facet paralysis is a potential medical emergency. So you need to start off with the identifications of how severe the motor involvement. Remember the first few slides I said about the severity of motor involvement. Once you have a severe muscle involvement, example like in this child with quadriplegia, you really need to look how to start and initiate your resuscitations. In fact, this child, when we look at it very carefully during that period, the child actually have very so-called paradoxical breathing due to the upper cervical involvement. You know, upper cervical cord also control our diaphragm. So this child is actually put on non-invasive ventilations. So what is more important, you want to maintain the ABC. So you want to ensure the airway protected. You want to make sure there's adequate ventilations. I mean, lots of time we are quite happy when the situation is okay. But remember, bearing in mind, adequate ventilation doesn't mean that only SpO2 or even oxygenations. You should always make sure there's no shallow breathing with the CO2 retention. So that is the reasons it's always very important for us sometimes to check a quick blood gas and see how is the CO2, particularly those are upper cervical involvement like in this child DLL. And of course, you really need a very close monitoring. If you're quite happy, yeah, the breathing is all right, no CO2 retention, it doesn't mean the child will not progress. In other words, that like even the case of GBS, they may continue to progress because the neuropathy may not be arrested yet. So the process of disease have not been arrested, please be careful. You need a close monitoring. If a child can be cooperative, of course, easier for us to do the peak flow monitoring, but of course, sometimes it's not easy for younger children. Then you may need to have a very close monitoring and vigilant about the possibility of deterioration. And next important thing is in certain cases, like if it's autonomic dysfunction, you always need to monitor the blood pressure. We do see certain patients of GBS with high fluctuating blood pressure, and also some of them may have tachycardia for unknown reasons. This could be all related to some sympathetic and parasympathetic dysfunctions. So checking the vital signs is very important. So as we always be careful about the possibility of this autonomia, which may potentially life-threatening. So in other words, not just the ventilations and also the airway, but please be careful other vital signs like the cardiac function as well. Of course, other things are more subsequent. This is more supportive care. When the child have a bowel functions impairment, don't allow feeding and the child get choked and aspirated. So certain patient, let's say if you have a child with GPS already got neck weakness, you know this is not a good sign. The upper limb involved, almost like quadriparesis with a neck weakness, you're not supposed to start initiate feeding. If you really want to start initiate feeding, please make sure the bowel function is okay. You either can refer to speech and OT for assessment. If not, please treat the child on tube feeding to be more safe if you were to start feeding for the nutrition purpose. And of course, the other thing is that a lot of children may have immobility. And remember about the DVT preventions, because lots of time we may miss that the child may not move the leg for 1 week and later on have deep vein thrombosis. So you can actually put the child on low molecular heparin, or you can actually put the child on the compression stocking to prevent deep vein thrombosis. And later on, you may need to initiate an OT and physio. But how about the specific management? It really depends on the underlying causes and underlying etiology. As I listed down, there are so many causes. But I'm just going to focus on these few important conditions that usually will be managed mostly by neurologists. Example, like you have tremulous myelitis. Of course, the drug of choice will be IV metoprolol. And in certain cases, if it doesn't work with the prednisolone, we will initiate plasmapheresis early. Of course, sometimes there are some roles of IVIG, but which is a bit controversial. So for GBS, the first line treatment is not steroids, it's definitely the IVIG. And of course, if those children who is not responding very well to IVIG, we will actually subject them to a plasmapheresis. Myasthenia gravis, also same like GBS, either IVIG or plasmapheresis. And others really depends on what is the underlying cause. If you have hypokalemia, you just need to correct the hypokalemia. If you have myositis, you know that's self-limiting. If you have autoimmune disease, you may need to treat with steroid as well. So it really depends on what is the underlying cause. But what is the more important message for the management is for us to stabilize the patient. When you see a child with acute flaccid paralysis, and before thinking about specific management, or before taking even more history. So I'm moving on for my next part of the talk. I'm going to talk a bit more the AFP surveillance. How much more time I have, organizers?
Dr. Teh, I think you have around 10 more minutes.
Oh, okay, that should be fine. That's good enough for me. Okay, that's good. Okay, I'll be fast. Okay. So anyway, AFP surveillance. We cannot run away talking about AFP surveillance in a child with acute flaccid paralysis because of the reason of poliomyelitis. And this is actually a pocket book of acute flaccid paralysis investigation for healthcare professional published by our Public Health Department, Ministry of Health. I mean, you can just look through if you're interested. Most of my information is adopted from there. So just a brief idea about poliomyelitis. This is actually a highly infectious viral disease that affects children less than 5 years old. And it's usually person to person, mainly fecal-oral route. And we know that poliovirus is a neuropathic enteroviruses, multiplies in the intestine, and it can invade the CNS, causing paralysis. In 1988, WHO adopted a resolution for worldwide eradication of polio, and marking the launch of this so-called Global Polio Eradication Initiative. You know, while poliovirus have decreased over 99% since 1988, from previously almost like 350,000 cases to only 6 reported cases in 2021. This is actually a huge so-called mankind achievement in terms of the virus eradications. And of the 3 strains, wild poliovirus type 1, type 2, and type 3, both type 2 and type 3 have been eradicated. Unfortunately, the wild poliovirus 1 still remains endemic in 2 countries like Pakistan and Afghanistan. And Malaysia actually have certified polio-free since 2000s. Unfortunately, if you know the recent update, there's polio outbreak declaration in Philippines in September 2019. And there's confirmation of one vaccine-derived paralytic virus poliomyelitis 1 case in Sabah in December 2019. And also there's another vaccine-derived paralytic virus, poliovirus 2, in Aceh, Sumatra in October 2022. And now actually, I think if I'm not mistaken, the ablation update already there are 3 cases there. You know, these are all our neighboring countries. Like Aceh is very close to Penang. That is the reason recently, just about a few months ago, WHO have visited Penang for the AFP surveillance, and they are looking very detailed in terms of how we are doing. I'm sure Kedah State is so near to us, I don't think they can run away from this importation of poliovirus if there were to be any cases from this Aceh. And because we have a lot of medical tourism, they are coming from Aceh, Sumatra as well. So the statement is that until polio is eradicated globally, importations can occur in any country, like our neighboring country is so close to us. So we need to really have a very strong AFP surveillance. We really need to notify and investigate all the AFP cases so as we don't want to miss any emerging poliovirus circulating in our community. So why we need the AFP surveillance? We know poliomyelitis cannot be diagnosed reliably on the clinical grounds. There are so many conditions, as I mentioned just now, presenting with acute paralysis can mimic poliomyelitis. So a very good AFP surveillance is very important for us to detect any emerging or introduction of wild poliovirus or even a vaccine-derived poliovirus quickly. So the targets of non-polio AFP rate for polio-free countries is 2 or more cases per 100,000 population aged less than 15 years. In other words, that for each of the 100,000 population children less than 15 years, we need to review at least 2 or more AFP cases And to prove that this is negative, to say we actually having a good polio surveillance, which is polio-free country. So like in Penang, we probably need to report almost like every year's 2 to 4 cases so as to make sure we reach the target. So what is the important is in terms of polio investigation, you need to have a 2 spool fulfilling the criteria adequate samples. You need to send to IMR within 72 hours. Yeah, we have actually have a check with IMR during the WHO visit. Nowadays, they can accept the samples of the stool even during office hour. You just need to call IMR and let them know this is for AFP, they will collect it. The reason being because the sample need to be processed within 72 hours because they need to actually have a validations of the lab findings or the lab results. Of course, all notifications need to be within 14 days of paralysis, and usually the public health officer will investigate the case within 48 hours, and you need to actually follow up 60 days for any residual paralysis. So the criteria of adequate stool, this is very, very important. Later on, we'll talk about it because it depends on the case classification. You need to collect both stool within 14 days after the onset of paralysis. So if the second stool taken after 14 days, it will be considered an inadequate stool or insufficient stool or a poor stool samples. The 2 samples need to take at least 24 hours apart, not within 24 hours apart, bearing in mind that. And you need to have sufficient quantity, which is an adult thumb size. The easiest is adult thumb size quantity. And the lab need to fulfill the reverse cool change, which is 2 to 8 degrees when they actually store the stool and also transporting the samples to the IMR. So why do we need a 2 stool for at least 24 hours apart? Because we know that poliovirus shed intermittently in the stool. So testing only 1 samples can potentially miss the virus detections. So the 2 sample more than 24 hours is to optimize the sensitivity and also to improve the chances of poliovirus detections. And this is considered to be a good polio or adequate polio stool specimen. So I'm not going to go details about AFP case management. You can actually look at our pocket books. It actually delineate very details about what they are going to do from the district health office as well as the KKM level. And this is actually very important for us to actually follow through the whole algorithms. But from our parts in the hospital, our job is to identify the AFP case and please notify as soon as possible. Of course, they say within 14 days onset, but it's good to notify as soon as possible using a specific form. Take the important 2 stool sample within the 14 days of paralysis and 24 hours apart. And remember to send the specimen within 72 hours using the AFP case lab request form. These are the 2 important forms you're supposed to fill up. The first form is the AFP paralysis case investigation form. Last time used to be faxed to the district health office. I'm not sure in Kedah State, but in Penang now we have emailed for us to send this investigation form. So you need to check with the district health office and see how they want us to actually notify the case. For us, I think we just email them because we have email address. And of course, this is actually the AFP case laboratory request form from IMR. So when you actually attach the so-called stool specimen, remember to actually get this form filled out properly. The most important thing is this date of stool. You need to know and how many days from the onset. Please fill out very carefully and appropriately. As I mentioned, we need to be within 14 days and collect at least 24 hours apart. Okay. So recently, DG have issued an important circular about this AFP surveillance. Of course, one of the things is the proper stool specimen, but the additional thing is that every state is supposed to so-called notify this so-called zero reporting every month to KKM. We know that last time we only report AFP case when you have a case, but now to ensure the surveillance is ongoing properly, and this is actually emphasized by WHO, so-called the expert when they visited Penang as well about this zero reporting. So even you have 0 case, you still need to report monthly to the health office and as well as the state level, and state level is supposed to need to notify KKM as well. And this according to the latest DG circular in March 2021. And of course, in the circumstances, sometimes we find it difficult to get a proper stool sample. Example, like you may have a child, myelopathy, they just can't pass motion. Is it okay for us to use the Levy enema? Yes, from the WHO expert, when they will be discussed, they say, yeah, you are allowed to use the Levy enema, but please make sure even using the Levy enema, you need to get a proper stool sample, adequate sample as well. But in the circumstances, let's say a child presents quite late to you. They make it at home, the child came to you at day 11 or day 12, then you get a first sample at day 12, then after that, second sample, you cannot get until day 15. What are you going to do? So if you cannot fulfill good samples, there are alternative ways. Within the 60 days, what you can do is that you can actually take the stool sample from 3 close contacts. The close contact can be the siblings or relative less than 5 years old, stay in the same room. Or you can be neighbors or friends less than 15 years old who actually staying in the neighborhood. Of course, you only need to take one stool sample from each of these contacts. And as I mentioned, it could be 60 days from the onset of paralysis. And this is actually just to make sure in case we don't have an adequate stool, we just want to make sure other contact will not have carried the polio virus as well. So finally, this is actually a case classification protocol. How do we know which case belongs to which case, like in terms of AFP cases? It's quite simple. When you detect the world polio virus, this is already confirmed poliomyelitis. If you detect the vaccine-derived polio virus, this is actually VDPV. When you detect the oral pyrovirus in the child given oral polio, it could be non-polio or it could be viral vaccine-associated paralytic polio. Of course, this one actually need to make a decision from National Expert Committee. I'm sure many of us will ask me about what is VDPV and what is VAPP. In a simple term is that in a certain country, some children were given oral polio and the polio virus sometimes can be excreted in the stool and circulating in the community. And for any susceptible children, they may get infected by this polio or vaccine-derived polio virus, and this will consider as vaccine-derived polio virus infections. Whereas when you are giving an oral polio and you seem to be having the so-called acute passive paralysis, then the expert need to decide whether this is actually a true vaccine-associated paralytic polio. In other words, that the VAPP is a side effect, considered to be a side effect of oral polio. Okay, so but when you don't have a polio virus, doesn't mean that you will classify a non-polio. It depends on the adequacy of the stool specimen. If a adequate stool specimen, simple. Non-polio, discard one. If you have inadequate stool sample, then you get a bit of troubles. No residual weakness is fine, then still discard two. But you have a residual weakness up to 60 days, then you will bring up to the National Expert Committee to consider whether this is a non-polio as a discard tree or polio compatible. So this will be an issue. So if you get a proper stool sample, then you can actually put a discard one. It will actually simplify a lot of the algorithm. So bearing in mind, adequate stool sample is very important. So finally, just show you some experience. I think this was published by Dr. Hussein Imam in 2014. You can see in this 5 years period, they have about 500 plus AFP. The overall rate of AFP, they reported about 1.2 per 100,000 children below 15 years old, which is not adequate. We need to report, I think, at least 2 or more cases per 100,000 children less than 15 years old. I think these are the major clinical diagnoses ranging from GBS, CNS infection, myelitis, non-polio enteroviral infection to hypokalemic paralysis. Of course, they didn't detect any polio virus due to the wild polio. Their 3 cases were polio compatible. Remember the last algorithm? This one I showed the polio compatible after the expert committee review. And of course, there are no cases of vaccine-associated paralytic polio or VAPP. So with that, I will give you some claim-home messages. Sorry, I think there's a spelling mistake. If you are still awake, not massages, okay? So the AFP is important for us to identify, and you need to have a systematic clinical approach. I have a thought throughout the talk. It is good to actually reach the diagnosis by starting off with the neuroanatomical localizations, then finding out the underlying etiology. Then, according to the clinical suspicions, we will actually tailor our investigation accordingly. And of course, remember, AFP could be medical emergency, so the management initially need to be supportive and followed by definitive. And finally, AFP surveillance is very important in the events of polio eradications, particularly for worldwide eradication program, and so particularly because recent outbreak in our neighboring country. So with that, I would like to thank you for your kind attentions. I'm happy to take any questions if you have any. I'll pass back to you, MC.
So do you have any questions from the audience? You can send your question to the chat box, or you can just turn on your microphone and convey your question to Dr. Tek before we move on to our break.
Good morning, Dr. Thank you for the excellent talk. Here. So I would like to ask, since the viral myositis and the cerebellar etiology also contribute to acute passive paralysis. In the clinical setting, do we really report the AFP and send for the surveillance?
Yes, yeah, this is very important questions. Thanks, Theo, for the questions. When WHO came to visit us, one of the message they want us to pass through is you have low threshold to report. It is okay in terms of over-reporting. The reason being because the more you report, at least we will pick up the likelihood of potential polioviruses. So in other words, that it is absolutely right for you to actually notify viral myositis, or even you think you cannot rule out whether it is cerebral dysfunctions or a true so-called weakness, it is okay for you to report. But having said that, please remember to take appropriate stool sample, because a lot of time you may report but ended up we don't have appropriate stool samples and you will maybe discard 3 or you need to bring up to expert opinion. That is actually the difficulty. So yes, to answer your question, yes, please have low threshold to report for any cases.
And for the second question, I'd like to ask is, so because in our district setting, sometimes probably a bit difficult for us to obtain the MRI spine within probably 24 to 48 hours of when the case presented to us. So if that's the case, for example, if we through GBS from our clinical finding, is it okay for us to start the treatment first, or is it a must for us to get MRI spine before initiation of any treatment?
Yeah, I think Neil, right? I think I heard that. Yeah, so okay, thanks. I mean, this is another good question, because in the local setting, that district hospital is always have limited resources, and I always think that it is very important for you to assess clinically first. If from the presentation is quite typical, you have aesthetic weakness, you have absence of reflexes, you have high clinical suspicions, you can actually consult us. And we, a lot of time, I think, as you know, sometimes we do ask you to start IVIG first without even an MRI spine. And at times, if we think it's equivocal, we cannot differentiate that. We will bring the child over and we will do the nerve conduction test for you. And that will be quite quick. We may not need the MRI, and this is under our control. You know, radiological department is not under our control, but NCS is under our control. And it can either refer to me or even in Penang, or even to Dr. Tan in Sultanah Bahia. We can do a quick NCS for you. But to answer your question in short, sometimes based on clinical ground, we do actually start IVIG. But of course, if you're not sure, you can always consult pediatric neurology team. Yeah, and MRI, as I said, is not a must. MRI, you know, sometimes it is just a supporting feature. Some of the GBI we have seen, they don't have a contract enhancement of the nerve root. And the other useful specimen is CSF. If your parents are consented to the CSF, that will be very helpful. You'll see high protein with a normal cell count. Yes, this is another very important clue. So I guess with the CSF finding, I will even start the IVIG. Even sometimes we may not even proceed with the NCS so quickly as well. Yeah, I'm sure. I hope I answer your questions, Neil. Any question in the chat box? I mean, you can just key in your question, is fine. I think if you feel shy to switch on your mic or even the screen or video.
So far, I don't see any question yet.
Yeah, I probably I can ask the questions to you all. How do you find when you're managing the child with AFP? Do you feel confident before and after the talk? Anyway, okay, I just want to know how your experience like.
I mean, I think in district level, I think it's a bit difficult for us. Well, especially as Dr. Neo mentioned, because sometimes you think the child has Guillain-Barré syndrome or anything we suspect of any infection. Sometimes the cases will be lying in between autoimmune and infection. So we are not sure. And then, yeah, I think it's a bit difficult for the district level.
I think this question is for me, Dr. Day.
Yeah. Hi. I mean, yeah. How are you?
Yeah, actually, on our side, we have a team of pediatricians here, so usually if there's doubt, then we will discuss amongst each other. But we're always very happy because when we refer to yourself or to Tan Teck Ang, there's usually an immediate response. So in that terms, detecting part is not too bad. But the decision when to give the IVIG, usually we are stuck at that now. Yeah.
Yeah, I guess probably there's a decision. Sometimes we also sometimes have difficulty, but based on the clinical ground, let's say the CSF, MRIs, then sometimes we do ask you all to initiate first. The issue is that I mean Kulim Hospital lying in between Alor and Penang, so we are more than happy to take your cases because geographically you are nearer to us.
Yeah, it's true.
Yeah, that's why I think always we are very responsive to Kulim Hospital because we know I think you're sending to Alor probably is further away from Penang.
Yeah, and sometimes the parents request to go to Penang because it's nearer. The difficulty that we do have is like Neo highlighted, the imaging part. MRI we have to do in Sungai Petani. So that is our major issue here.
Right. Okay. Thanks, Lavinia.
Thank you.
I think there's a question.
Sorry, Dr. Teh, I think Dr. Kong has a question here.
Yeah, yeah.
So what is the significance of labeling a case as polio compatible?
Yeah, so if you remember, thanks for the question, Kong. If you remember the case classifications, the reason why we want to do a case classification is that we want to be highly vigilant about the possibility of circulation polio. So when you have a case of polio compatibles, which means that we cannot rule out polio, the health staff public health may do a bit more investigation in the community. So for the polio compatible cases around that area, sometimes they may need to actually go down to the close contact. They may need to go down to the so-called the surroundings. Sometimes they even do the fluid around the area to make sure there's no polio virus circulating around that areas. So in other words, it's definitely very important. Polio compatible means you cannot rule out polio. Definitely the public health will have more job to do. Of course, they will go down to level, as I mentioned, close contact and even to the community around that area to make sure there's truly no circulating polio around that community. So it is important. That is the reasons why they need to bring out to the expert committee level to decide it. Yeah, hopefully I answer your questions.
Is there any more questions? Okay, thank you so much, Dr. I think I think you have delivered a great talk that we have learned a lot from you from your talk. And then so now we are going to move on. Now we are going to have our tea break until 10:30. So you may have a small break, then we will resume our talk at 10:30 by Dr. Sindhu regarding preventive treatment of epilepsy in tuberous sclerosis. Thank you so much.
Okay.